in surgery, and my lecture today is on pneumonia, and I thought I'd do a bit of chest X-ray revision. I'll vary it with, I will ask you directly. Some of it can be, you can just shout out. But what I want to try to do is, these are so close to the end that I want to try to get you to think about when you're in the exam, because you probably know most of this already, but it's to try to push you so that when you're answering the questions, you do it in a way that the examiner thinks they know what they're talking about. This isn't a student that I have to worry about. This is a definite pass, because on the day it's mostly nerves that get you. You probably know most of this already. So some of my top tips that when I was doing my finals, these are here. So it's exam focused. Make sure you know what have come up other years. Things are repeated all the time. For the OSCE, we used to work in groups of 3, 1 examiner, 1 student, 1 patient, and we would just rotate. And it helps if you're varied, like different levels of how good you are, because it tends to bring the weakest member up, and it will also help the other two. Just you kind of feed off each other, and we thought it worked really well. If there's anything that you are unconfident about, like, just don't shy away from it. Just force yourself to become more familiar with it. I don't know if you guys like get to see your mark sheets, but we used to like make up our own mark sheets and think, what is it that the examiner is going to want from us on the day? And yeah, just like keep practicing. I mean, for us, I knew that when you wake up in the morning and you've been having dreams about what's coming up in your OSCE, that's probably when you're doing a lot of revision, because you're honestly just so saturated with it, you're dreaming about it and waking up in the middle of the night, like, just running through your heads like OSCE stuff. So yeah, just good luck, and I wish you all the best. So today I'm going to do community and hospital-acquired pneumonia and some chest X-ray stuff. So just shout out some symptoms of pneumonia.
Cough.
Yeah, cough. Yeah.
Fearless eating.
Yeah.
Shortness breath.
Yeah. Fever, yeah.
Chest pain.
Chest pain, yeah. Anything else? Yeah, yeah. So yeah, those are all really good symptoms. Just one of them, just fever, like fever's more of a sign, so it's just, I'm just trying to get you to think, when they ask you the questions, what have you been asked? You're completely right, fever is completely right, but it's just think about what you've been asked, do it in a systematic way when you're answering the questions. So yeah, that was really good. Okay, community-acquired pneumonia, what is it? So you've got signs and symptoms of a lower respiratory tract infection, you've got focal chest spines, you've got consolidation on your chest X-ray, and you've got systemic features of sweating, aches and pains, fever, which you said. So some risk factors. Elderly, yeah, depends what type, but yeah, what organism, elderly, yeah. Anything else?
COPD, smoking.
Yeah, smoking, other lung conditions.
Immunocompromised.
Yeah, very good, yeah. Anything else? Any other comorbidities that might make them more susceptible?
Diabetes.
Yeah. So smoking, COPD, diabetes, immunosuppression, and yeah, elderly people who live in nursing homes. Okay, so I'll be Jane, and I come into the emergency assessment unit. So I'll pick on somebody, nobody looking at me, which is the standard response. So I'll go for the guy in the blue hoodie with the white. Okay, what's your name?
Pete.
Pete. Okay, so I'm Jane, and I've come to AMU, and I've had a cold for the last week. I'm not really feeling too good. GP's put me in. I came to A&E, and I'm sitting there. What do you want to ask me?
Okay. Hi, Jane.
Hello.
Hi. So, how are you feeling?
I'm okay. Just like got a bit of pain. I've had this cold like for a week, and it won't go away. Just not feeling myself. Haven't been at work.
Can you describe the pain for me?
Yeah, it's worse when I breathe in. It's kind of just like here on my chest. It has been there for a week now. It seems to be getting worse, and I've been like, maybe it's just like to do with my cough because I've been coughing loads as well.
Does it feel sharp or dull?
It feels sharp.
Okay. And are you coughing as well, you say?
Yeah, I've had a cough. Yeah.
You bring anything up?
Yeah, I bring up like a greeny yellowy coloured sputum.
Okay. And how much are you bringing up?
Not that much, like just like a tablespoon. Not much.
Any time of day that it's worse?
No, not really. I think it's just there all the time.
Okay. And have you felt unwell in yourself, like any?
Yeah, I just don't feel right. I feel kind of hot and sweaty. Not really feeling myself. Just been in bed. Yeah.
And you said that you had a viral infection before. Do you think it's like a cold or?
Yeah. Well, I thought it was a cold, but maybe it's something else. I mean, now I'm in hospital, but yeah, just haven't been well for the last week.
Okay. Have you had chest infections before?
No, this is my first one. Never had one before, no.
And any conditions that affect your lungs?
No, not that I know of, no.
Okay. Anyone else in your household unwell at the moment?
No, they're not, no. I live with my husband and my little boy, but no, everything's fine.
Okay. Have you been sick?
No.
No. Any changes in your bowels?
No, fine. Okay, we'll leave it there because you're moving from the chest side. Yeah, like really good. You kind of let me talk and then take a focused history. So yeah, great. So when you examine me, so you find that I've got pleuritic chest pain. I'll move on. So the girl beside him. So I've got pleuritic chest pain, I've got the cough, you've been through the history, I am a smoker. So what you want to do next is you want to examine me, yeah. So this is what you find on examination. So I've got a cough, productive, dry and sputum. My observations show I've got a fever, I'm short of breath, aching all over, I've got this cold sore. No past medical history, and I was an old smoker. So, on examination, I've got this pleuritic chest pain, dullness to percussion on the left. I'm short of breath, and I've just got maybe mildly reduced expansion on the left. So, what would you want to do next?
Chest X-ray, do some bloods.
Is there anything missing, any other information that you'd like from my observations that would be useful with anyone who's short of breath?
Just like respiratory, heart rate, blood
Yeah.
pressure.
Yeah, so first thing to look at is the observation. So I've given you the temperature, so the rest rate, your saturation is really important. Am I tachycardic? Am I on oxygen while I'm sitting in front of you? And urine output. Okay, fine. So with what I've given you, so does anyone know what organisms, or can anyone name me the top 3, say, organisms that cause community-acquired pneumonia? Yeah, so that's really good. That's the most common one. Anyone know what the next one is? Sorry? Yeah, Haemophilus, and the one after that? Maybe one before that? No? Okay, so yeah, so strep pneumoniae, Haemophilus influenzae, the 2 most common and the big ones to get. Legionella is the next one, Staph aureus, and then Mycoplasma. So does anyone know what one she might have had, based on what I gave you? So yeah, so what did she have on it? Yeah, so does anyone know what organism that makes it more likely to be? So it's the top one, it's just strep pneumoniae. So most common pathogen, we've talked about how it presents, and it's just like an MCQ point of view. If we've got cold sores, it tends to be more strep pneumoniae, associated with increasing age and comorbidities. Okay, so we've got a young boy now. So I'll go for the guy man in the high-vis jacket. So my name's Joe. I'm 18. So is there anything that you think that puts me in more a likely genre to get a more likely organism that we've talked about before? Young male, in the younger age group, is there any organisms that tend to be more likely to get in that one? No? Okay. Anybody?
Hemophilus?
No, not Hemophilus. Not Legionella. No? Okay, so we'll talk through this one. So he's had a dry cough. You think he might have an atypical pneumonia. So in some of the things that you were going to want to send away, cold agglutinins, is this ringing any bells to anybody else? No? And he's got some deranged LFTs. So again, from an MCQ point of view, if you're hearing deranged LFTs, cold agglutinins, he's a young guy and his friends have got it too. This is typical of mycoplasma. This tends to occur in younger people and has like 4 yearly epidemics. And the deranged LFTs come from the hepatitis. So does anybody know any, this is for a crunchy, extra pulmonary manifestations?
Diarrhea.
No. Or give me the proper word.
Arthralgia?
Yeah, arthralgia. Yeah. Who said it? Yeah, arthralgia is one. Any others? No. So yeah, arthritis and arthralgia, autoimmune hemolytic anemia, neurological manifestations that can be central or peripheral, pericarditis, myocarditis, hepatitis, glomerulonephritis, skin things like Stevens-Johnson's and erythema multiforme and DIC. Okay, so another organism that we mentioned before, so Staph aureus, associated with influenza infection, more common in the winter months, and high incidence in ICU. So these are just kind of like buzzwords to look out for your MCQs if you get a question about microbials. Okay, so Archie, so ask somebody else. So the guy at the top in the red tie.
Hi Archie.
Hello. So I'll tell you a bit about myself. So I've been a smoker for 80 years now. I've got a cough. I'm running a temperature. I'm really confused. He's not obviously going to tell you that he's got hyponatremia, but you do some blood tests and that's what they come back as. And I've just come back from a holiday in the Mediterranean. Is there any buzzwords there that make you think of anything?
Holiday in the Mediterranean.
Yeah, what does that mean? Yeah, Legionella. And where do we commonly find that? Yeah, like air conditioning and like water cooling systems. Okay, so how do we assess these people? Yeah. So C. More importantly, yeah. Yeah, so new confusion. Yeah. U. Yeah, urea more than 7. R. More than 30. Yeah. B. Yeah. Systolic less than 90. Yeah. Okay. So you want to score them, but it's not. We don't strictly just go by the score. There's other prognostic indicators that we look at as well. So if you run an ABG, are they hypoxic? Looking at the chest X-ray, is there multi-lobe involvement? Do they have positive blood cultures? And looking at their white cell count. Okay, so we did that. You're on that. So yeah, the curve score just gives us an indicator of mortality. Obviously, the more severe it goes, the higher your mortality. Okay, so we talked about investigations. And the other things that you want to do. So we've talked about community-acquired pneumonia, typical and atypical. So these are just you're screening the urine for the Legionella, and an atypical serology for mycoplasma. Okay, so how do we want to manage this? So someone. So yeah, you who's obviously playing on your phone.
Sorry.
No, that's fine. I'm joking.
Yeah, remind you.
Yeah. Just the management of
Pneumonia.
pneumonia.
Oh, right.
Yeah.
Antibiotics.
Yeah, so yeah. But so say I'm your examiner. So I'm going to give you management. So you're an F1. So what are you going to do first? So yes, antibiotics is going to come into it, but give me it in a logical order.
So depending how unwell they are, if it's an acute situation, if they're acutely unwell, then I'd approach them using an ABC sort of approach. I'd like to give them some oxygen for breathless.
Yeah, so oxygen first, great, yeah.
Maybe do an ABG if the sats are low. Then look at their observations, see if they're tachycardic, hypotensive. Maybe give them some fluids if they need it.
Yeah, so fluids is part of the management because
Yeah.
they'll be dehydrated. Yeah.
I'm sorry, I missed out. Maybe give them a nebulizer as well, or
Yeah, you can do.
In B. And then, so once they're stable, then I can move on and maybe think about giving them steroids, antibiotics, and that kind of thing.
Yeah, so antibiotics, yeah. Yeah, so antibiotics. Do you have any idea? I mean, in your exam, if they were to ask you, every trust does have different antibiotics that they use, but do you guys know what it is for our hospitals?
Erythromycin, Comox, for community acquired.
So,
Depends on the
clarithromycin,
severity of the
yeah.
COPE scores, if it's IV or oral.
Yeah, and there was another one I could hear.
Amoxicillin.
Yeah, amoxicillin, yeah. And it does depend on the severity. Yeah.
Trust.
Okay. Yep, so you said all that. Okay. So an important point about antibiotics is when they come in, yes, if you haven't taken the blood cultures yet and you don't know what organism we're working with until you hear from microbiology, broad spectrum's fine. But because we don't want to increase the incidence of MRSA or C. diff, you want to use a narrow spectrum antibiotic, which is what you mentioned. We'll want to use, we want that call from microbiology to hear what this bug is sensitive to. So yes, broad spectrum's fine, but just as a learning point, we want to narrow it down. Okay, and then follow up, so you'll recheck chest x-ray in 6 weeks. Okay, so to prevent this happening, any vaccinations? Yeah, and yeah, so influenza, pneumococcal, and stop smoking, obviously really important. Okay, so hospital acquired. So this is just a pneumonia occurring 48 hours after admission to hospital. So possible organisms, quite similar to community acquired. Some are associated with things that can occur in hospital. So strep pneumonia, Haemophilus influenzae, more associated with trauma. Staph aureus associated with head trauma and with or without ventilation. Pseudomonas associated with COPD and intubation, and anaerobes with abdominal surgery. So risk factors for hospital acquired. Sorry? Stroke, yeah. So CVAs, yeah. Anything else?
Mechanical ventilation.
Yeah, ventilation. Surgery. Yeah, so prolonged-use antibiotics, surgery, which you said, do they have a chronic lung disease? Are they elderly, immunosuppressed, ventilation and intubation? Okay, so we're just going to talk through now some of the different types. So we've got ventilator-associated, aspiration, pneumonia and immunocompromised, environmental source, so that's Legionella, and spread of communicable disease. So 2/3 of patients who are ventilated over 48 hours will get ventilator-acquired pneumonia. Mortality of 15 to 50%, and it's usually caused by a breach of your defence against the bugs by the endotracheal tube insertion. Aspiration is the commonest cause in people with neurological conditions, and 10% of drug overdoses will get aspiration pneumonia. So chemical pneumonitis, so this isn't an infection, it's inflammation, and you need about 25 mils of your gastric contents to get this. It's a very quick process. We've got this collapse of the alveoli, you get hemorrhage and edema, and it's easily be seen on a chest x-ray. Prophylactic antibiotics do have a role, but we generally support these patients. Okay, so we've talked about management before, it's the same, but you just use a different antibiotic for hospital-acquired pneumonia. Okay, so complications of pneumonia?
Effusion. Sepsis.
Yeah. Empyema. Abscess.
Perfusion.
Yeah. Anything else? Okay, yeah, I think he's got most of it. And two of you said, one said long abscess, one said empyema. Does anyone know the difference? I'll give you another crunchy.
Is an abscess contained within the layer of epithelium?
Empyema is a pleural and infective, possibly purulent pleural.
They can both have pus in them. That's not what I was looking for.
Empyema is the pleural space.
Yeah, so it's not necessarily, because you can have like gallbladder empyema, so it's not necessarily pleural space. But you're on the right lines. The difference is that an empyema is a natural cavity that you have, so you've got pus in your, so like with a lung empyema, you've got pus in your pleural space, whereas a lung abscess, you've got necrosis happening, so you've got cell death and necrosis, which forms this, it's not a natural cavity was there, this is an erosive process, and you get necrotic material, and you can get pus within that. So that's the difference between the two. It's just an important point, just because I didn't know when I was a medical student, and it can come up. Okay, so prevention, so stop smoking, early mobilisation, pre and post-op, and hand hygiene, really important for every kind of hospital-acquired infection. Okay, so we'll do now a bit on chest x-ray. Okay, what's this? Yeah, normal. So really important to be able to recognise normal, first of all. Okay, so how to read chest x-ray. Again, I'm not sure if this is a station in your OSCE, but we definitely had it in ours. And all they're looking for is that you have an approach. It's just that they don't want to see you going in there. Yes, you might get that they've got a pneumothorax, but they don't want to see that you're missing, that they've got a fracture of their humerus. You know, they want to know that you're looking at all the bones, the heart, the lung spaces, and that you're not just going straight to the diagnosis. So with anything, whether it's an ECG, an ABG, an X-ray, just if you've got a system, I'm sure you're almost there. So name, date, projection, and it should say all that on it. And you should never interpret anything in an exam or in the hospital without those things. Orientation, quality, and then just like I said, have a system for how you're going to go through it. Everybody has a different one. Mine was more going through the landmarks from the left-hand side to the right. Some people like doing the lung spaces, the heart, the bones, the soft tissues. So it's whatever works for you. So things you want to comment on is a good inspiration. So the diaphragm should lie at the level of the sixth rib anteriorly, and the right is usually higher than the left because the liver is pushing it up. Is the rotation, so you should see this, the spinous processes of the vertebrae. And they should be like midway between the clavicles, and do you have good penetration, so you should just be able to see the lower thoracic vertebral bodies just through the heart there. So, like I said, this is just the way I do it, but I used to just start at the top and go around from the aortic knuckle onto the left side of the heart. So just make sure you're commenting on the mediastinum, the trachea, the borders. Okay. Sorry, these are a bit heavy, and you can go back and read them because we've talked about it already. Okay, so collapse versus consolidation. So in collapse or atelectasis, you've got this blockage of the air passages, and that can be the bronchus or the bronchioles, or by pressure outside the lungs. So when the lung is not aerated, it loses its volume and and it collapses in a predictable location. So whether that be whatever lobe, the right, the left, the middle, and you're just looking for this pattern, and I'm sure you know the pattern with when each lobe collapses, what it looks like. Okay, so some risk factors for developing collapse. So anesthesia, if there's a foreign body, coexisting lung disease, mucus plugging, pressure on the lung, prolonged bed rest, and shallow breathing or obstruction from a tumour. So consolidation. So your lung face should appear black, and consolidation appears as like a pacification. And this can be from infection, it can be from fluid, it can be from blood, and it can be from pus. So it's just important to keep in mind that when you say consolidation doesn't mean pneumonia, consolidation doesn't mean infection. It can be either of those things. And consolidation typically has these air bronchograms, which is just the air passing through, and you've got this background of the opacification, which will appear as white either side. So they're like little black tubes. I'm sure you've seen them. Okay, so anyone give me any causes of a complete whiteout? Yeah, so effusion. So there's two main ones. So effusion's one. Sorry?
Okay.
Yeah, so yeah, removal of the lung. Yeah, there's another more common one. No? So consolidation. Yeah, pneumonectomy. So consolidation and effusion are the two big ones. And collapse of the lung. Okay, so which one of these is effusion and which one's consolidation? And tell me how you know. Anybody?
Fusion on the left.
Yeah. On the right.
My left?
Yeah, your left.
This one.
Yeah.
Is it not on the right?
Plural.
The
This
fluid
one's
level on the
pleural
right.
effusion.
Because of the fluid level.
And this one is the consolidation. Yeah, does anyone know how we can tell the difference? So yeah, there's a meniscus on this one down here, and although it almost looks like a meniscus, if you were to look at it, it's not actually a fluid level, that's not actually a meniscus there. But yes, there is a meniscus on the one down here. Anything else?
Is it bronchogram on the left?
This left?
Yeah.
Yeah, so there's presence of bronchograms, which would imply that there's consolidation. Yeah. Yeah, so this one is left lower lobe consolidation. So two key features is that there's no fluid level and that there's no loss of volume within the lung and there's no mediastinal shift, whereas on the that one there we do have this fluid level and the mediastinum is just pushed over to the left. So those are two things that you can use, because sometimes fusion and consolidation can look really similar. So it's just important things to look out for. Okay, so just going to finish off with some chest x-rays. So I want you to interpret like you would in your OSCE. So does anyone want to have a go, or will I choose? I'll give you a crunchy. Sorry? Okay, so you told me what you think it is, but I want you to interpret it as well. As annoying as it may be.
Well, you can't, there's not a name or the...
Exactly, yeah, really good.
You can't really see if it's rotates because it's not full screen part of it.
Tell me what you can see.
The lung fields appear clear. If you look at the highlight, they're larger than normal. You can see both phosphenic angles. Looking at the ribs, there doesn't appear to be any abnormalities there, soft tissue as well. Can't see the air on the diaphragm.
Yeah, okay. So, like, really good. Like, you know what it is because you just told me, and you told me what the abnormality is. But like, if you're in an exam, it depends what level you all want to be. But the candidate that will stand and stare at the examiner and say, so if the name, the date, and the what film it was on it, so you say that. And then if you were to go through your system and say, I can see the lung fields that are black, there doesn't seem to be any evidence of pneumothorax, I can see both postphrenic angles, I can see both heart borders, the most obvious abnormality is bihilar lymphadenopathy or enlargement of the hilum bilaterally. My diagnosis is sarcoidosis. It's just about, I'm just trying to like get used to practice that, because you all know what it is, and it's about practicing that on the day will make you look like this guy knows what he's talking about. So really good, like you know what you're talking about, just practice a bit more, like reporting chest x-rays, because that's what will get you like honours or distinction or whatever you guys get. Yeah, so really good. So oh, do you want this? Sorry. So I've got no more crunchies left. So yeah, does someone want to interpret this one? And just give it a go, like telling it to me like you are the best candidate that I've seen today. Yeah, go ahead.
So you've got a chest x-ray, but you don't know if it's AP or PA.
Yeah.
You can't tell who it is because you don't have any of the identification on the x-ray. When you look at the quality x-ray, it looks okay, but you can't see whether it's rotated or not because you can't see the clavicles definitely. I think it is okay. It's on the screen. You've got 6 or 7 ribs, so you've got a pretty good expansion. You can see the vertebra through the heart, so you've got good penetration. You've lost your costophrenic angles a little bit on the right, right, and quite a lot on the left. And it's indistinct left heart border as well, in the where it is the costophrenic angle. The heart looks enlarged, but you can't say for definite because you don't know if it's AP or PA. You've got some diffuse shadowing on the right low and low, I would say. That's probably all the abnormalities.
Okay.
Yeah, here central, there's lung markings equally on both sides. You've got consolidation or small pleural effusions.
Okay, so do you want to tell me what you think it is?
If it's a large heart with some signs of heart failure.
Yeah, so yeah, you're right, it's heart failure. And do you know there's like an easy way to remember the signs of heart failure?
ABCD is...
yeah, so what have you got?
Oh yeah, you've got alveolar shadowing. You've got curly V lines, which I think you can see.
Yeah, exactly.
You can see fluid in the fissure anyway.
Yeah, there's a fluid line. And you knew that, but you just didn't tell me, so
curly
exactly.
lines, upper lobe diversion.
Yeah.
Cardiomegaly and...
You're on E.
Yeah. Oh, effusions.
Yeah, bilateral effusions. Yeah. Yeah, so really good. Yeah, you did it in a systematic way. Just like, just practice. Like, you could have told me what that was. Yeah, great. Just keep practicing that. Okay, yeah, really good. Okay, the last one. Do you want to go?
Okay, so you don't have any identifiers on this chest X-ray. You don't know whether it's PA or AT. The quality of it looks good, doesn't look particularly rotated. You can see the kind of comedy stuff, vertebra behind the heart, and it appears to be good enough expansion. You can see plenty of room. So the abnormalities in the right upper lobe, it looks like, well, it's homogeneous shadowing, which with a raised hemidiaphragm on the right-hand side, which suggests upper lobe collapse.
Yeah.
And on the left, it's hyperexpanded. And you can't see the left cosphenic angle. You can see the right. Otherwise, there are lung markings in both fields to the edges. Can't tell whether the heart's in line. It doesn't appear to be. No worries. So there'll be abnormality.
Okay. Yeah. So what do you think?
Upper lobe collapse on the right.
Yeah. Okay. Upper lobe collapse on the
right upper lobe.
Yeah. Sorry, that's me. Yeah, really good. So yeah, you went through it in a systematic way, and you came to the diagnosis. So yeah, really good. That's it. Does anybody have any questions?
You know how the definition of hospital pneumonia is